Looks good.
Great. Okay, so I'll get started by talking a little bit about myself. I won't read you the bio I've written here, but I'm a New Mexico native. I'm from Los Alamos originally. I went to high school at Los Alamos High, did my undergrad at UNM in biochemistry, did my med school at UNM, and now I'm in my second year of psychiatry residency at UNM. In my spare time, I enjoy tennis, weightlifting, snowboarding, gardening, and I'm happy to be here with you guys. As was mentioned earlier, there's a link at the end for continuing education credit, as well as evaluation. I have no financial arrangements related to the content of this activity, and the views expressed in this presentation are my own and do not necessarily represent University of New Mexico. Today we'll be talking about borderline personality disorder. Our objectives are to describe BPD epidemiology and comorbidity, recognize features of BPD and employ a simple rating scale, identify effective BPD therapies and their common features. Originally, I had put this presentation together for crisis intervention teams, which is the branch of law enforcement that largely goes out into the community, brings in and evaluates mental health related crises. And so while this was initially developed to talk about kind of how it affects law enforcement, I think most of the information, really all the information is appropriate for healthcare providers. So in talking about personality, we first need to define what personality is. That's a complex topic. So we can look to the American Psychiatric Association definition of personality. They define it as the way of thinking, feeling, and behaving that makes a person different from other people. An individual's personality is influenced by experiences, environment, and inherited characteristics. And a person's personality typically stays the same over time, but not always. So we can think about pathologies that alter personality. The most classic example is the individual Phineas Gage, who in the 1800s, he was he was working on railroads, and he was a foreman and had a metal pipe basically that went through his brain. It went through his left frontal lobe, and he had extreme personality changes. And that was one of the first incidences where people were kind of linking brain function to personality characteristics. We can think about pathologies like stroke or frontotemporal dementia that alter personality. But in general, we think of personality as a pretty stable structure over time. Whenever we think about personality, we need to consider culture. Personality is influenced by culture, and in making judgments about personality, we have to consider an individual's background. For instance, a person's reliance on an abusive relationship in a small community where divorce is prescribed, it may not reflect pathological dependence, whereas in someone else that might be pathologic. We can increase the accuracy of our diagnosis by paying attention to these culturally patterned conceptions of self and attachment, the bias that we bring from our own perspective and backgrounds, and bias from the diagnostic tools we use that may not be generalized to a population of interest or to the individual that we're assessing. Social modulators, sometimes called social determinants of health, including poverty, acculturative stress, racism, and discrimination, also affect personality characteristics, and the way people cope with their surroundings. There are sex and gender considerations here, specifically for borderline personality disorder. It's historically diagnosed more frequently in women versus men. And there's a kind of historic tie to diagnoses like hysteria, which was a diagnosis given, kind of came about in ancient Greece. The prefix means uterus, and this was it thought that a lot of behavior in women was related to the uterus. And the term hysteria made its way all the way through, was only dropped by psychiatry in the 1950s. Borderline personality disorder has historically been diagnosed in about a 3-to-1 ratio of females to males, but we find that in community samples, there's no gender difference in prevalence. In clinical samples, we still see that there is a female predominance. What's the reason for this? You know, some of it could be historic. We could think about cultural gender roles, such as help-seeking behavior, which may contribute to the discrepancy. It's also possible that that men have historically required a higher severity of symptoms for providers to make that diagnosis. I should also mention that we don't yet have enough data to make definitive claims about differences in prevalence in transgender populations. So now that we've defined personality, what is a personality disorder? Very simply here, it is a way of thinking, feeling, and behaving that deviates from the expectations of the culture, causes distress or problems functioning, and lasts over time. We don't need to go through all these criteria, but this is sort of the categorical way that the DSM-5 text revision defines a general personality disorder. So not specifically borderline, but any personality disorder is defined as an enduring pattern of inner experience and behavior. It deviates markedly from expectations of the individual's culture. It's inflexible, pervasive, leads to distress, stable over time. It's not better explained by another mental disorder, medical disorder, or substance use. So the DSM now includes 2 different approaches to evaluating personality disorders. The more historic way of doing this is called the categorical approach, where you have a set of criteria. It defines personality disorders as qualitatively distinct clinical syndromes. Basically, if you meet 5 of 9 of these criteria, then you have this disorder. In 2013, there was a committee put together to look at a different way of defining personality disorders. They define these as they represent maladaptive variants of personality traits, which merge imperceptibly into normality and into one another. The categorical approach is imperfect. Basically, it neglects that symptoms and traits can vary along a gradient of severity. So, for instance, for borderline personality disorder, you must meet 5 of 9 categorical criteria, meaning that there are 256 possible different combinations to have that diagnosis. And criteria sets like this lead to heterogeneity within diagnoses. So 2 patients could receive a borderline personality diagnosis and share only 1 criteria. That's one of the reasons that this 2013 committee was put together. The alternative model looks first at severity, because with personality disorders like borderline, there's a wide range of functioning. Some individuals go through life, they're able to maintain employment, relationships, and many of them, as I'll talk about later, will at some point in their lives no longer meet diagnostic criteria, whereas other individuals remain at high risk of suicide, high levels of distress, hospitalization, and alienation from their support systems. The alternative model, it was designed to be flexible, focus on level of personality functioning rather than presence or absence of a set of criteria. And research indicates that the severity of personality dysfunction is the most important predictor of concurrent and prospective dysfunction. Okay, so here I just have a picture of basically the way the alternative model of diagnosis works. So we first assess the impairment, the severity of personality functioning. We then assess pathologic personality traits, which include negative affectivity, detachment, antagonism, disinhibition, psychoticism, and then apply those to these models that we have of personality disorders. This alternative model is thought to provide a coherent model for characterizing myriad clinical manifestations of personality disorders. It's been judged to be more clinically useful, and its components have been shown to be useful in planning treatment and predicting outcome. That being said, I'll focus a lot today on categorical criteria because I think it's a nice way to conceptualize and develop an intuition for recognizing personality disorder signs and symptoms. Here we have a diagram with all 10 of the personality disorders included within the DSM-5 TR. We can break these down into the different clusters. Cluster A is thought to be disorders that are of an odd and eccentric flavor. Cluster B, dramatic and unpredictable. C, anxious and fearful. You can see that borderline personality disorder falls into cluster B. And so sometimes we may not definitively know that someone meets all the criteria for borderline. They may have some overlapping criteria of some of these other conditions, such as narcissistic, histrionic, borderline, antisocial. So we'll talk about borderline epidemiology here. This is typically not seen as a coherent clinical syndrome before the age of 12. And adolescence is considered a very sensitive time for development of borderline personality disorder. The point prevalence at a particular time is 1.6%. And a lifetime prevalence of 5.9%. So that sort of hints at how we have good outcomes and how things can change. About 20%, different studies show potentially as high as 25% of psychiatric inpatients meet diagnostic criteria for BPD. There are no known systematic racial or ethnic differences, but studies on this are few. 85% of BPD patients have at least one comorbid mental disorder, and most individuals have 3 to 4. These commonly include depression, anxiety, PTSD, eating disorders, and substance use disorders. I've included the prevalence percentages for females versus males for these bottom 3. I didn't include them for depression and anxiety because they really are so prevalent that various studies have different numbers, but it's 75 to 90%. Very commonly, patients have depression, anxiety. I think the question that follows from that is, are these other comorbid conditions, do they stem from the borderline? That sort of depends who you ask, but you can imagine that with the kind of affective instability that comes with borderline, it makes sense that there could be some comorbid conditions. We don't necessarily, though, say that the depression emerges from the borderline. This is in part due to the way we classify our diagnostic system is partially for billing and research purposes. But clinically, it helps for us to think about the depression, anxiety, PTSD, all the comorbid conditions, and borderline as how they come together to affect the patient. Patients with borderline have an elevated risk of infectious diseases such as HIV, hepatitis, as well as endocrine, metabolic, cardiovascular, and respiratory diseases. The mortality rate with BPD is double that of the general population. Why is this? Well, a core feature of borderline is impulsivity. You can see high risk taking behavior in some patients with BPD, and that certainly could contribute to things like substance use, which will increase risk of infectious diseases. BPD is associated with low occupational attainment, low educational attainment, lack of long-term romantic relationships and friendships, increased partner conflict, sexual risk-taking, low levels of social support, low life satisfaction, increased service use, and high levels of psychotic spectrum disorders. The essential feature of borderline personality disorder is a pervasive pattern of instability of interpersonal relationships, self-image and affects, and marked impulsivity that begins by early adulthood and is present in a variety of contexts. So while we'll look at many of the different signs and symptoms, of borderline, I think it's helpful to always go back to how this is the essential feature and a great way of conceptualizing the developing your intuition for recognizing borderline. So I would be remiss to not include the full diagnostic categorical criteria for borderline personality disorder. So here are the 9 criteria. So the top portion here, pervasive pattern of instability, that's what we had on our last slide. And at least 5 of the 9 following criteria: frantic efforts to avoid real or imagined abandonment, pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation, so that can be called splitting behavior. Third criteria is identity disturbance, a markedly and persistently unstable self-image or sense of self. Fourth is impulsivity in at least 2 areas that are potentially self-damaging. This can be things like impulsive spending, impulsive sexual activity, substance abuse, reckless driving, binge eating. Fifth is recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. 6 is affective instability due to a marked reactivity of mood. 7 is chronic feelings of emptiness. 8 is inappropriate, intense anger or difficulty controlling anger. And 9 is transient, stress-related, paranoid ideation or severe dissociative symptoms. And we'll talk more about this. On this slide, I've broken down the prevalence of these various categorical symptoms. And you can see that the affective instability present in 95% is really a defining core feature. In fact, I believe it's the ICD-10 coding looks at diagnosis of this condition instead of borderline personality disorder. It's considered affective dysregulation disorder. And that may be an appropriate way to think about this pathology, is that it's really an impairment in the regulation of one's moods and affective states. So we'll work through a few cases here to talk about some of the individual symptoms and to see kind of the range of severity we can see in borderline. So we have a 17-year-old female patient admitted to the emergency room after attempting suicide by overdose. Although her act had been impulsive, prompted by a breakup with her boyfriend, she had been hoarding the medication beforehand in case she could no longer stand it. Her home life was difficult, filled with violence, but she did not want to talk about that experience during admission. She reported having struggled with suicidal thoughts, self-harm, and significant bouts of loneliness since the age of 12. The self-harm acts had started as superficial razor blade cuts to her forearms, but recently had progressed to inflicting deeper cuts in her genital area. And when this was ineffective in relieving her intermittent, unbearable feelings of distress, she would resort to alcohol. She expressed little concern for little concern for her physical well-being, hatred of her body and person, and had recurrent episodes of unreality and out-of-body experiences. She rejected counseling because she felt she did not deserve to be well. A few days after admission, her boyfriend indicated that he wanted to reconcile, after which she reported that everything was fine and requested discharge. So you can think for a few seconds here about what characteristics of borderline personality disorder, what criteria you see in this presentation. I've highlighted a few of them on this next slide. This is a presentation that highlights how there can be a very high level of danger, and that there are going to be individuals who meet criteria for hospitalization. A true suicide attempt will absolutely meet criteria for hospitalization. And one thing that's particularly dangerous about this presentation is that she was hoarding medication beforehand in case she could no longer stand it. So not necessarily a planned suicide attempt because of major depression, but planning to be in essentially a state of high emotionality, potential dissociation, a state where impulsivity could be very high. And that's a state where that contributes to the mortality. Patients with borderline personality disorder have an 8 to 12% suicide completion rate throughout the lifespan. What else we see here? This is triggered by a relationship conflict. It's very common that triggers for borderline crisis are things like abandonment or kind of perceived neglect. And we see that there is cutting behavior. Self-harm is common in borderline personality disorder. Shame, this kind of hints at that sense of the feeling of emptiness that one might feel. Unreality and out-of-body experiences. I'll talk some more about dissociation in a few slides. And then everything kind of improved for her when the boyfriend indicated he wanted to reconcile. So kind of that borderline injury was repaired. When we have a presentation like this, there are many different symptoms and signs that you're noticing. And to make better sense of that and see if it really does meet criteria for borderline, it can be helpful to utilize a rating scale. One of our earlier rating scales, and a pretty simple one to administer as a clinician, is the Zanarini rating scale. It's an empirically valid measure of borderline personality disorder symptoms. But I should mention that the majority of participants in the trial for borderline personality disorder were white British adults. They were all in contact with mental health services. So the results may not generalize to adolescents, community samples, non-clinical samples, or people with different ethnic or cultural backgrounds. And the questions on the Zanarini scale pretty closely mimic what's in the categorical criteria. So we ask about if people's closest relationships have been troubled by arguments or repeated breakups. We ask about self-harm, deliberate self-harm. We ask about problems with impulsivity. We ask about moodiness. Have you felt angry a lot of the time? How about acted in an angry or sarcastic manner? Have you been distrustful of other people? So kind of hinting at paranoia. Have you frequently felt unreal or as if things around you were unreal? So depersonalization, derealization, dissociation. Have you chronically felt empty? Have you felt that you had no idea of who you are or that you have no identity? Have you made desperate efforts to avoid feeling abandoned or being abandoned? So I'll pause here in case, does anyone have any questions at this point? Okay, I will go ahead and move on to the next slide. Oops. Okay. So the function of self-harm. Self-harm is thought to reduce aversive tension and terminate dissociation. Sometimes patients will say that they cut or they pinch or they hit their head on things to kind of bring them back to reality, bring them back from the distress that they're feeling. It has been associated with stress reduction. I should also mention that while self-harm behavior like cutting is typically not for the sake of ending one's life, it can become deadly when things get out of control, particularly if someone is very impulsive and dissociates. The cuts can become deep. They can lead to death or surgical intervention. Other kind of self-harming behavior can be very dangerous as well. Banging one's head on walls can be done very, can be really hard, can lead to traumatic brain injury. So here's our second case. 54-year-old female high school teacher presented to a psychiatric outpatient clinic. Although she was coping adequately at the professional level, she had been experiencing extreme strain, mostly due to the retirement of her current therapist. Over many years of therapy, some aspects in her life had improved. She was not self-harming anymore, was managing to live on her own, but she felt infinitely lonely and empty. She was unable to cultivate social relationships and needed all of her energy for her job. Life felt like a quiet sea of desperation. Somatic problems such as joint pain, headaches, and migraines had increased, which she believed was due to the large number of medications she was taking. So you can think briefly about what signs of borderline you see in this presentation or signs of other pathologies. Again, I've highlighted some of the features that stand out to me. This particular crisis was triggered by the retirement of her current therapist. So that's something that can be perceived as abandonment. It can be perceived as, it's loss of a relationship. But this case also highlights the variation in severity. This is someone who's functioning pretty well, holding down a job, but still struggling to maintain social elements within her life. So is unable to cultivate social relationships, still feeling very empty. And we see that this is an individual who has somatic complaints, which is not something we saw in our first case. Somatization is the production of recurrent and multiple medical symptoms with no discernible organic cause. In borderline personality disorder, there's a substantially elevated risk of somatic disorders, which can include fatigue, dizziness, nausea, vomiting, abdominal pain, bloating, diarrhea, chest pain, weakness, and all kinds of other symptoms. Sometimes comorbid with disorders of somatic pain, such as fibromyalgia. Any questions on those last few slides or that case? Right, so we'll move on to case 3. We have a 36-year-old male patient who came looking for therapeutic support after his wife told him that she wanted to separate and take their daughter with her because she was fed up with his escapades. He reported feeling intense rage and hatred towards her and worried that he might seriously harm her. Due to instances of domestic violence, social services had already become involved, and he feared that he might not see his daughter again. When asked, he revealed that the marriage had always been filled with screaming arguments. Most physical violence had been directed against objects, but there had been 2 incidents where he had assaulted his wife when she threatened to leave him. After these outbursts, he felt deeply ashamed and miserable. His last employment was with a security company, which he terminated after believing that his colleagues were out to get him. He acknowledged that this had been a typical pattern for him in his work life. So again, we have a crisis that is provoked by a social situation, a social crisis. This is the first case we have of a male, and this is a presentation characterized by intense rage, hatred, some dissociation. We see that this is someone who has kind of failed throughout life to develop control of the affective dysregulation, and remains at risk of continued arguments, continued violence, escalation of violence, and does have shame, feels miserable after these events. One thing that's notable in this presentation is this sense that colleagues were out to get him. Sometimes patients, despite having no kind of physical evidence that someone is out to get them, will just have a sense, this really strong paranoia, feel like they're missing something, even though they can't back it up with evidence. There will be a sense that someone wants to abandon them, someone wants to do something negative to them. The affective dysregulation in borderline personality disorder can be characterized by intense rage reactions, extreme efforts to avoid abandonment, which can include things like harm of others or self, and dissociation. It's, I think, important to differentiate this kind of dissociation from what we see in a lot of psychotic disorders. This dissociation occurs when the affective dysregulation is so high. It occurs when someone is really identifying strongly with the experienced emotions. There's a concept called psychic equivalence, where basically one is identifying so strongly with the experienced emotions that reality sort of falls away. The psychic equivalence is that the experienced emotions do in fact represent reality. There's no difference from one's sense, one's feelings, emotional feelings of reality, and reality itself. So those feelings of abandonment or feelings of paranoia that someone's out to get them truly represent reality. I've heard patients say that when in these states, when they do take dramatic actions, like they run to grab all their pills to take, or they find themselves abusing their spouse, they reflect on it with great shame and say, you know, I feel like I just blacked out. I felt like I wasn't even there, and I wish I hadn't done that. So why does borderline personality disorder occur? There remains no empirically supported integrated etiologic model for BPD development. There are thought to be genetic, neurobiologic, and psychosocial factors that combine to cause BPD, and the relationship between BPD and adverse childhood experiences is not understood. However, there does appear to be a heritability component. A recent study found they pinned heritability at about 46%. And two studies found the concordance rate for BPD was higher in monozygotic twins compared with dizygotic twins. So suggesting that there is, you know, a non-negligible genetic component there. The neurobiology is also not perfectly nailed down. There are disturbances in a corticolimbic circuitry involving the amygdala, hippocampus, insula, anterior cingulate, orbitofrontal cortex, and medial prefrontal cortex that seem to contribute to the symptomatology. We do know that amygdala hyperreactivity is more pronounced in BPD versus both healthy and depressed populations. There's also a hypoactive prefrontal cortex, which is related to a lot of our executive function, a lot of the top-down regulation, conscious regulation of our behavior. So you can imagine that if the amygdala is hyperreactive and we have increased fear, disgust, anger, and a hypoactive prefrontal cortex, we can't consciously regulate that behavior as well. There are also some recent studies suggesting that there is a hypoactive hippocampus and a hyperactive posterior cingulate cortex. And for anyone who follows any sort of psychedelic medicine, psychedelic medicine has sort of highlighted the role of the posterior cingulate cortex in its how it's related to self-identification. So when people are given psychedelics, there's sometimes something called an ego dissolution, and that's thought to be related to silencing or hypoactivity induced by the psychedelics on the posterior cingulate cortex. And I imagine that since, you know, that causes a kind of de-identification with surroundings and emotions, we could imagine that here in BPD, if there's a high hyperactive posterior cingulate cortex, there could be a high identification with emotions, and that potentially could be related to how there is that concept of psychic equivalence, where one identifies so heavily with the emotions that it is indistinguishable from reality. So what acute interventions do we have for borderline? First of all, we always want to differentiate between what represents a suicide attempt, non-suicidal self-injury, and what is high-risk behavior, such as preparatory behavior or rehearsal behavior. So preparatory would be like our first case, where the young woman is hoarding medications in preparation for a suicide attempt. Rehearsal behavior would be if someone has tied a noose, that would be preparatory, but then they put it around their neck to see what it would be like. Or they have an unloaded gun, which they point at themselves, or they potentially pull the trigger. We want to offer outpatient crisis intervention whenever possible. Sometimes an inpatient intervention is not going to be that helpful for someone with BPD. The hospital environment sometimes can be somewhat infantilizing and induce some kind of regression in symptoms. So if inpatient intervention is required, we aim for a short duration, and we want to initiate discharge planning on day one. We always want to ensure that any children are appropriately cared for. Crisis intervention should focus on concrete problem solving. We want to create strategies to prevent or handle future crises and prevent future hospitalization. And we want to avoid inpatient hospitalization if the behavior is not immediately life-threatening. Longer-term management. Drug treatment is not indicated for borderline personality disorder, but it can be useful to manage comorbid conditions. So the depression has historically and is largely handled by SSRIs, but for more severe cases of borderline, there's use of mood stabilizers and antipsychotics for impulsive behavior. One medication to avoid in borderline personality disorder is benzodiazepines. While they can do a great job of curbing the anxiety, it can be a very risky choice in individuals with pathology marked by impulsivity. And so giving a benzodiazepine can increase the disinhibition and possibly provoke impulsivity. The best long-term management for BPD is psychotherapy. It appears to alter emotion regulation by altering neural activation and connectivity. There are a large number of effective psychotherapeutic modalities, which include dialectical behavioral therapy, which is a form of cognitive behavioral therapy that was specifically designed for borderline. There's mentalization-based therapy, which helps with perspective taking. That's something that is particularly difficult for individuals with BPD. Transference-focused therapy, cognitive and behavioral therapies, schema-focused therapy, and a therapy called good psychiatric management. Let's see. I'm not sure what year this was. It was I think it was 2007. There was a meta-analysis of 27 randomized controlled trials demonstrating that various therapies are effective for improving BPD outcomes. So you can see that the significance of many of these randomized controlled trials crosses our line here of significance favoring psychotherapy over control. And these are for various types of therapies that were studied. In a study of dialectical behavioral therapy, amygdala and prefrontal activity changed substantially after patients were instructed to apply different emotion regulation strategies, such as reappraisal, distraction, and pain. Oh, their reappraisal, distraction, and pain were altered by the therapy. Common elements of effective psychotherapy. So 75 or 80% of the effectiveness of psychotherapy has to do with these common elements. So if one therapeutic modality doesn't work for a particular patient, doesn't mean that other therapeutic modalities or a different therapist won't provide benefit. So up to 80% of the benefit of these therapies comes from largely an empathetic environment, clear setting, transparent framework, informed focus on borderline personality disorder, individually consented targets, active, supported, and challenging therapist, a validating atmosphere, balance of acceptance and change, continuous attention to affect, teaching skills, providing competence, self-efficacy, continuous focus on motivation and collaboration, and the development of crisis plans to, again, prevent further and future hospitalization. Outcomes have improved, largely because of the effect of psychotherapy. A 2018 meta-analytic review synthesized findings of 11 naturalistic and post-treatment follow-up studies in 837 adults. They found that the mean diagnostic remission rate, meaning patients who no longer meet the diagnostic criteria, categorical criteria, was 60%. And so this sort of raises the question. So as we defined personality as a structure of thinking, behaving, and feeling, that it's stable over time, if we're saying that 60% of these individuals have a change in this, can we really call it related to personality? Perhaps it's more appropriate to call this an affective dysregulation disorder because that is its core feature. The American Psychiatric Association guidelines for borderline personality disorder management are: develop and maintain therapeutic alliance, interact with patients in an active and empathetic manner and validate their experiences, encourage patients to take responsibility for their actions and problems, maintain regular appointments that patients are expected to keep, establish clear boundaries with respect to the treatment relationship and patient behaviors, set limits when necessary to maintain those boundaries. It's important to mention here that borderline is a clinical term, not a pejorative. Sometimes it is commonly used as a pejorative statement because these can be patients that elicit a high degree of countertransference, which is those feelings from the clinician that we feel about the patient. What's happening when we notice that countertransference is we're noticing the features of this person's maladaptive behavior that has likely pushed them away from their social support. That can it can represent just an absence of alternative coping mechanisms, which can stem back to the childhood trauma or the genetic or psychosocial factors. Even the folks who do not develop borderline personality disorder might be affectively intense, but potentially without that childhood trauma that some have, they never go on to develop a clinically distinct syndrome. Here are my references. And here is a QR code for evaluation and to get your continuing education credit. So I will go ahead and open things up for questions now. Alex, I can't hear you.
We'll just give it a few more minutes if anybody has any questions for Dr. Whicker. And then we also just shared the CE link in the chat. For those requesting CEs, let Shanti or I know if you have any questions regarding CEs.
And I would like to thank you, Dr. Whicker, for taking time and presenting today. And I also thank you everyone for joining today's presentation. If you have any question regarding CEs, please feel free to email me directly.